Is it visible, the slideshow?
Yeah, visible.
Yes, visible, Antony.
Yeah, I'll
audible
yeah.
Also. Very good.
Yeah, recurrent chest infections is a very interesting topic, as well as a very, like a wide topic as well. I'll try to do justice in 25 minutes. I try to simplify lots of things. Hope I am not oversimplifying things. And I, at the outset, thank Dr. Palniraman and all the organizing team for including me in this scientific bonanza. And recurrent respiratory infection, recurrent chest infections. As I said, there are not lots of evidence, how to approach recurrent chest infection. All the evidence comes from retrospective studies and expert advice. What I'm going to do in the next 25 minutes, we'll see what is normal in a case of a child presenting with recurrent infections, and what are the red flags we should be worried about, and how we are going to approach these children with recurrent respiratory infections. And finally, I'm going to summarize. Recurrent chest infections, is something not only hospitalists, but also people in outpatient practice frequently encounter. Frequently, a family with very anxious parents come to the doctor and say, my child is getting frequent chest colds. Please do something about it. And we can see their anxiousness in the way they talk, actually. And it's our duty to identify, which condition they fit into. There are three groups of recurrent chest infection. And the first group is the commonest one. It's a usually healthy child with recurrent respiratory infection. And the second commonest will be atopic child. These two contribute about 80% of the patients. Therefore, we are not going to see, a very abnormal child to begin with, but we should be very careful that, 1/5 of the patients can have a serious underlying disease. And it's our duty to, identify these patients early on. And most of the patients, if you are seeing an outpatient practice, would require referral to a tertiary center. And the next few slides, we'll see how to differentiate all these three conditions by just clinical evaluation without doing much of investigations. We know that healthy children can have up to about 10 respiratory infections in a year. And most of these infections are going to be viral respiratory infections. The infections, though they resolve in 1 or 2 weeks, some patients can have persistent symptoms like cough that can last for about 3 to 4 weeks. Therefore, we should not be worried about the duration if it is less than 4 weeks and the infections are less than 10 per year. In addition to that, it's very, very important we should get into the habit of plotting the weight on a growth chart, because if the child is not thriving, that is not a healthy child. And we should also look for atypical features, which I will come to, in a separate slide. I will show all the atypical features. But at this time, we have to reassure the parents, but we should also try to identify there are some risk factors that can, happen to that particular child, like common risk factors. You have to identify those risk factors, which are somebody smoking at home, or the child being exposed to some environmental pollution like firewood, smoke exposure. And we have to check whether they have given the vaccinations properly, and is there any overcrowding in the house, or is the child attending daycare at a very young age, and is there lack of breastfeeding. All those things we have to look, and we try to identify the risk factors, and we have to address those risk factors. It is also important if the patient comes to you for the first time, we need to follow them up, make sure they don't develop any atypical features, or they don't develop any growth failure in the next 6 months to 1 year. Therefore, even though we were not doing much of investigations here, we just need to keep them under our follow-up. The second group of children is atopic child who gets frequent wheeze with a viral respiratory infection. And in this situation, we have to follow GINA. What GINA tells is we have to assess, treat, and review response. The assessment, what we have to do is we have to confirm the diagnosis, and we know that wheezes the confirmation of diagnosis is only clinical. This is usually a clinical diagnosis. Probably we might need to do an X-ray to exclude alternate diagnosis. No high funda investigations necessary as long child is otherwise healthy. But we need to look into the spice factors. What are the spice factors? How about the symptom control? Is there any psychosocial factors that aggravate the problem? And what about inhalation therapy? What medicines they are taking and what dose, and whether taking the medicines properly, the adherence, all those issues and the technique, everything we have to look into it. And we should also look into the comorbid conditions that might, aggravate the V's. And again, here also we have to look at the exposures and number of exacerbations in the previous few months. And based on this, we are going to formulate a personalized treatment for that patient. Personalized treatment doesn't mean just giving drugs, lots of health education, and we have to treat modifiable risk factors. What are the risk factors we have identified? And it's also important to keep these children under follow-up and review for response. If the child is not responding, again, we have to reconfirm the diagnosis. And we should also, because lots of medications can have side effects. At the same time, when we look for response, we have to look for side effects as well. The third group of children is very important for us to identify, and there will be definitely some red flags in the history and physical examination. We have to search for it. What are the red flags that we commonly see? Neonatal onset of symptoms might indicate child might have a genetic problem, and any feed-related symptoms might indicate child might have aspiration syndrome. We have to look and evaluate for that. And early onset persistent wet cough might indicate a suppurative process which might be silent. And as I said, we have to plot these children on growth charts. We have to look for growth failure. This is very, very important. And we should also look for clubbing, any unexplained hypoxemia, blue spells. These are, real red flags. On the auscultation, or if you hear any abnormal noises like stridor or wheeze, especially monophonic wheeze, you have to be a bit careful. And in addition to the respiratory system, there might be clues in the extrapulmonary system. Therefore, you have to look other systems as well for any clues that might help with the diagnosis. And another important thing we might miss out is taking good family history. There might be a history of a genetic condition in the family which might recur in the child, or there might be sibling deaths. This is very important. Therefore, if you find any of these, red flag signs, it might indicate child might have an underlying serious disease. And in this situation, I think we have to consider definitely early referral to a center where there is facilities to do diagnostic tests. If and lots of conditions, previously we thought we could never treat. Now, treatments are available, and they can be life-changing as well. Therefore, important, if you find atypical features, if you are not able to evaluate, better refer to a center, tertiary center. And while evaluating these children, is important not only take a good history, physical examination. It's important to review the previous medical records and also to review the serial X-rays. They might have they usually come with a pack of X-rays. You have to, patiently look at those X-rays. Based on this, you can identify clinical syndromes. The two important syndromes we can identify is recurrent pneumonia, the first one. Recurrent pneumonia, by definition, 2 episodes of pneumonia in a year or 3 episodes in any time frame. The important thing is this is radiologically proven pneumonia, and in between episode there should be clinical and radiological clearance. The second phenotype which we can identify based on our evaluation is persistent pneumonia, where there is clinical and radiological evidence of pneumonia which lasts for more than a month, and there is no clearance, symptomatic improvement, clearance in between, even with antibiotics. Not only you have to look at the opacities, but you should also look at the distribution of opacities. That will help in further evaluation. In the serial X-rays, if you see, the opacities are in the same lobe, is going to be a localized disease. If it is going to be in different lobes, it's otherwise called multifocal disease. Etiologies will be totally different. As I said, same lobe is going to be straightforward, okay? Therefore, the pathology will be in that particular lobe, either parenchymal like a congenital lung lesion or some airway disease. Therefore, investigations, apart from infection screen, you have to do a CT scan chest, and if necessary, a bronchoscopy will arrive at the diagnosis. I will give 2 examples. This is a child who had a recurrent shadowing on the right lower lobe with infections. And we evaluated, I will show only the CT scan for this particular patient. And we also did CT scan with 3D reconstruction. You can see in the CT, in that particular position, there is a sequestrated segment of lung. Sequestration is diagnosed by absence of bronchial connectivity. There won't be any bronchial connection, and it will be supplied by a systemic artery arising from this patient from the aorta, the supply. Therefore, this is the focus of infection. The patient was treated by surgical intervention and is doing well. The second patient is shadowing on the right upper lobe. Again, I will show the diagnostic investigation. This patient had a bronchoscopy which showed endobronchial granulation tissue with caseation, which you will be able to, I think, see. And we did a biopsy, and the pathology was very typical of tuberculosis. Therefore, I said like only 2 investigations if it is a localized disease process: CT scan as well as bronchoscopy, and along with that, we have to do infection screen. If it is going to be a multifocal disease, then it's not going to be straightforward. It's going to be very challenging. Therefore, we should have some checklist. I have a checklist of 5 items whenever I evaluate multifocal pneumonia. First in the checklist is, what is the bug? We have to ask this question. What bug we are dealing with? In India, I think we should not forget tuberculosis. We should do evaluation for tuberculosis. But sometimes you can get unusual organisms which can be disease defining. When you get a child with pneumonia, recurrent pneumonia, if you isolate Pseudomonas, that might indicate the child might have a disease like cystic fibrosis. If you isolate opportunistic infections, probably you are dealing with immunodeficiency. Therefore, the first thing I will ask in a child with recurrent pneumonia, multifocal diseases, am I able to isolate a bug which can give the diagnosis? The second in my list is how good is our defenses? And we all know that our respiratory tract has a 3-layered defense, like developed country which has Army, Navy, and Air Force. Our respiratory tract has got a 3-layered defense. Mucociliary apparatus, and the bug has to cross this. It's very difficult. It's like ugly. It's very difficult to cross. And then if it crosses the mucociliary apparatus, it has to encounter the phagocytes, innate immunity, as well as the proteins, which are like missiles. And then if it passes through this, then it has to face the adaptive immunity, T and B cells. Therefore, our immune system is quite strong, and we have got barriers. Therefore, an infection to become recurrent has to pass through all the barriers. Therefore, we have to ask, are our defenses getting weak? I'll show a condition where the mucus is a problem. CF, in CF, the mucus becomes very thick because of lack of hydration. The CFTR protein is important for hydrating the mucus. I have got a very interesting video. I think if you have not gone through this will tell you what exactly happens. This is our mucociliary apparatus and functioning normally, and the cilia is beating and the mucus is not very thick. Therefore, the mucus blanket is moving nicely, and the CFTR is functioning normally. Now you see the defective CFTR protein. Therefore, the ion channel is not working. The hydration of the mucus is not there. The mucus becomes very thick and it blocks the tubes. Therefore, in cystic fibrosis, the problem is thick mucus blocking the tubes. And the clinical manifestation in Western countries, they usually do a neonatal screening and identify. Therefore, they don't wait for the clinical syndrome to evolve. But in our patients, like what we see early on is a triad of recurrent chest infections, failure to thrive, and if you closely watch for oily stools, you can identify oily stools as well. This is a triad we commonly use to diagnose cystic fibrosis. But they can also present by other means. Neonatal period, 20% of CF present with meconium Therefore, any meconium you have to evaluate for cystic fibrosis. They can present purely like a malabsorption syndrome initially with loose stools and edema and anasarca. And another interesting finding in countries like India, tropical countries, during summer, children get admitted with dehydration and salt loss. In diarrheal dehydration, you get, when you do electrolytes and blood gas, you get metabolic acidosis. But in this condition, there will be dehydration there, and when you look at the serum electrolytes, there will be metabolic alkalosis with electrolyte loss. Therefore, during summers, if you find any child sick and dehydrated, if you see metabolic alkalosis, it could be cystic fibrosis or Bartter syndrome. And when you identify the clinical phenotype, you have to confirm the diagnosis. For that, you can do a sweat chloride or genetic testing. The next condition with the mucociliary apparatus is, the cilia is not functioning normally. It's called primary ciliary dyskinesia. The cilia doesn't work properly, the mucus won't get clear, the child will get recurrent infections. And here you can easily suspect PCD by looking at 4 cardinal features. One is like if the child had neonatal respiratory distress, which is unexplained, that's some first cardinal feature. These children can have situs anomalies, that is the second feature. Situs anomalies like situs inversus. Third is persistent upper respiratory symptoms. Usually persistent nasal discharge, they will be very snotty, they'll always have purulent nasal discharge. And these children also have intermittent ear infections. The fourth is persistent early onset lower respiratory. We said initially upper respiratory, this is lower respiratory, usually in the form of wet cough, and later on they can have bronchiectasis. If you can identify any 2 of these 4 cardinal features, you can make a clinical diagnosis of primary ciliary dyskinesia. Here, the investigations are not straightforward. There is no gold standard investigation. You usually use a combination of 4 tests, 2 upfront tests like nasal nitric oxide and nasal brushings for ciliary motility. The confirmatory test will be either you can do genetics or electron microscopy. They all have their positives and negatives. I'm not going into the details of it. And we'll move on to the case scenario. This is a child who presented, this is going to be straightforward, 4-month-old boy who has, on the X-ray, you can see multilobar pneumonia, and he has got oral candidiasis, opportunistic infection. He is failing to thrive, and there is sibling death. Therefore, it's a genetic condition. There is a multilobar pneumonia with extrapulmonary involvement and opportunistic infection. Therefore, you satisfy the SPUR criteria. SPUR is severe, persistent, unusual bugs, recurrent infection, runs in families. And if you closely look at the X-ray, you have to get into the habit of looking at thymus in children with recurrent infection as well as pneumonias. Therefore, this time, up to 2 years, you should be able to see some amount of thymic tissue. Here, thymic shadow is totally absent. Therefore, absent thymus. Everything points towards immunodeficiency. And how are you going to do a PCD screening? PID screening. Everybody should know nowadays, because we have treatment facilities, and PID screening is not very difficult to interpret. In our center, we always do a HIV before doing a PID screening, because sometimes we miss HIV and then screen with all the investigations for PID, later on only diagnose HIV. Therefore, it's important to screen for HIV before PID. CBC will give lots of clues. Dr. Palani Raman will tell. And you have to get into the habit of looking at absolute neutrophil count, which will tell about the phagocytes, and absolute lymphocyte count, which will tell about the T and B cell combined. Therefore, you have to look at it. CBC is a very useful investigation screening test. Then for T and B cells, we usually do a lymphocyte subset analysis, as well as we also do a immunoglobulin profile. For phagocyte, apart from ANC, we also look at a test called NBT.
Dr. Antony? Antony? Dr. Antony?
Hello? Hello?
Yeah, it's your voice is
Able
Hello?
to hear now. Able to hear now.
yeah.
You can go ahead.
Breaking.
Yeah, now you.
Proceed.
Now you are okay. Now
Yeah.
you can hear me.
Yeah.
Yes.
Yeah. Therefore, this is the PID screening we do, and later on, if necessary, we go for advanced tests, is for advanced flow cytometry and genetics. And this patient had absolute lymphocytopenia, and we looked at T and B cells. T cells were very low. T cell marker is CD3. It should be more than 300. That's a cutoff. It's only 64. Everything points towards severe combined immunodeficiency. Child also had an opportunistic, extra opportunistic infection in the lungs. We identified, like pneumocystis jirovecii by methenamine silver staining. And we talked about, bugs, defenses. Next is neighbors. Sometimes neighbors can be friends, sometimes they can be foes. But in recurrent pneumonia, we have to definitely look at them. And aspiration pneumonias are an important, cause of recurrent and persistent pneumonias. Therefore, aspiration could be due to swallowing dysfunction, anatomical defects or GRD. And there are tests, like pH study as well as video fluoroscopic swallow study to identify aspiration syndromes. Therefore, this is one patient. We have done video fluoroscopy, and you can see the contrast spilling into the bronchi. And the bronchoscopy confirmed, the site of the tracheostomy fistula is in the lower third above the carina. And the other important neighbor is the cardiovascular system. You can have problems with the heart, congenital heart disease, as well as vascular system. They can create trouble as well, can cause recurrent respiratory infection. You can diagnose by echo and doing a CT angiography. And the fourth in the list is the foreigner. You have to ask if there is any foreigner inside the respiratory tract, because toddlers is very common, and sometimes it won't be easy to diagnose clinically after the acute phase. Therefore, it can become a retained foreign body and present as recurrent infection. And bronchoscopy will be diagnostic as well as therapeutic. And here is one patient who presented with persistent right lower lobe shadowing, turned out to be foreign body groundnut in the airways. And there are others which can mimic. They are not infections. They can mimic infections. They can present with shadowing of the lungs on the X-ray. That is pulmonary hemorrhage, hypersensitive pneumonitis, lipid pneumonitis, and interstitial lung disease. And these things are not very common, but they can mimic infections. We should also keep them in mind. Therefore, I have gone through my checklist. By this time, I will be able to diagnose most of the conditions. And what happens if the chest X-ray is normal? What happens if the chest X-ray is normal and child has recurrent infection but atypical features? Therefore, chest X-ray is not a foolproof investigation. Sometimes it can be deceptive, because airway diseases can be missed out on a chest X-ray. Parenchyma is good, but for airway diseases, you can miss out. In those situations, especially a child with chronic wet cough can develop from PBB to bronchiectasis without our knowledge. Chest X-ray can be absolutely normal. Chest X-ray probably picks about 10 to 20% of bronchiectasis. Therefore, when there is chronic wet cough, I think you have to definitely consider doing a CT scan and bronchoscopy. And this is what CT will show, but X-ray can be normal. And this is what bronchoscopy will show. X-ray can be normal. Here on the left side, you can see bronchiectasis. On the right side, you can see airway malacia, inspiratory and expiratory film. Expiratory film showing occlusion of left lower lobe bronchi. The CT can be normal as well. Therefore, in summarizing, recurrent respiratory infection are quite common in children. It's very important to note vast majority of children are going to be healthy and atopic children. It can be managed at primary care. But when you find atypical features, I think you have to make an early referral. Serial X-rays will be able to help us in identifying clinical syndromes. And when you identify clinical syndromes, you have to go in a systematic manner, like you should have a checklist like what I had. And when you have recurrent respiratory infections and atypical features like wet cough, even if the X-ray is normal, you should not be reassured. You can miss airway diseases like bronchiectasis, which can be easily reversed when identified very early. Thank you very much.
Thank you, Antony. I think you have presented excellent